So we're gonna get off here. So in the United States, we kind of go by our Kidoki guidelines, which there's a lot of people in hemodialysis. There's a lot of people that have hemodialysis intervention, and this is all trying to be a little bit more clinical based on the Kidoki guidelines. So why do we do fistulogram or evaluate fistulas? Because at this point, we're not doing it for diagnostic purposes in a sense. Most of those patients that are sent to us are because their fistula is not working well, or because their fistula is having some issues during dialysis. So mainly we're doing it for therapeutic intervention, but obviously we will have to know where the problem is. And then all the other stuff comes with dialysis intervention. So eventually the fistulogram that we do is the gold standard to kind of like take care of these patients. And it can be done a variety of ways, and we're going to go through that. If the patient is allergic to contrast, you can use CO2. However, you don't want to do the CO2 close to the arterial anastomosis, but you could evaluate the patient's fistula in the arm or lower extremity if it is placed there with CO2. So sometimes it's really hard to evaluate the entire fistula, depending on what the problem is. Like failure to mature is one of the things that we might have to get access to the arterial anastomosis just to get, or the arterial side, just to get the arterial anastomosis location before we start any intervention. With that said, our fistulas that are placed here most of the time are brachiocephalic fistula. And I'll show you a couple of things. So brachiosemial fistula will be the ideal fistula, which is the one that is created around the wrist. And that is one of the only ones that has a particular name. It's one of the fistulas that actually lasts for a longer period of time. So over the period of the past 5 years, we have been changing from fistula first, creating a fistula for patients, to peritoneal dialysis catheter. And the reason for that is because we're trying to save veins as much as we can. So currently in our institution, what we tend to get more is those peritoneal dialysis catheter to be placed first. And then those patients will last probably around 2 or 3 years with those peritoneal dialysis catheters before they actually start on hemodialysis. And that will actually increase the possibility of the patient sort of like have more years on some sort of dialysis. These are the most common ones that we tend to see. The majority of them will be mostly a radiocephalic fistula. We don't see it. Sometimes we see it in the forearm, but the majority of the time we will see it in the arm. Some sort of different type of intervention, either a real brachiocephalic or brachiocephalic fistula or a transposition fistula. The majority of the time we will see that. So when do we do intervention? And I will get to cases in a few minutes. I just want to give you the overview. So we tend to do fistulas intervention when the patient has failure to mature, which means that the fistula is not working well from the beginning of the creation. Usually we wait about 6 weeks after the fistula is created to sort of start doing dialysis. But sometimes they don't get to fluation in about those 6 weeks. And when they measure flows, the flows are really low. So we tend to have this rule of 6. when we know that a fistula is created well, which is 6 millimeters in diameter, 6 centimeters in length. You want a flow that is about 600 milliliters per minute, and about 6 millimeters from the skin. So those rule of 6 is what we tend to use to sort of like know the fistula is actually working appropriately. But failure to mature has a lot of implications, and usually the problem is that there's not really good inflow. So the arterial anastomosis usually has a problem, or there is a big draining vein close to the arterial anastomosis that needs to be closed or embolized, and those are competing veins. So this is the rule of 6. There's other, the fistula can be clotted. So what I usually tend to ask is, why is the patient presenting? Is it because an inflow problem or an outflow problem? If the patient has a arm swelling, or if the patient has poor cannulation or poor flows during dialysis. So we need to know where in that circuit is the problem. And that's why we sometimes evaluate this type of things. All right. So where did usually you will see stenosis during the fistulas, during the fistulograms? Usually it's at the point of bend when they create those fistulas. That's where you usually see it. So there will be probably around the proximal anastomosis that where you see fistula, or around the areas of high flow, which is cephalic arch. We'll see a lot of fistulas, stenosis. But the reality is you do have to evaluate the whole circuit from the arterial anastomosis to the central veins to see where the problem is. And usually you can determine where the problem is because of the presentation of the patient. So arm swelling will be more of a central part of a problem, versus failure to cannulate will be probably a little bit more of an inflow problem. So advantages to having a fistula is that the fistula usually has a better patency as opposed to a graft. They have low rates of infection, low rates of thrombosis, and it's lower cost to maintain versus grafts that tend to be a little bit more of a flow problem. But the disadvantages will be failure to mature, and it's about 30% of fistulas that get placed that have an issue. And that's the reason why sometimes we spend a lot of time trying to fix them so that they don't get another intervention. In AV grafts, at least in our institution, or close to our institution, we do get what is called we do get 6 millimeters or 8 millimeters diameters a graft. The majority of the time, the grafts are 6 millimeters in diameter. They're synthetic grafts. Sometimes they're loop grafts, sometimes a straight graft. But we do get more grafts than fistulas most of the time to fix, because they do tend to go down a little bit more. So you can see the forearm loop graft or a straight graft here, or it could be a straight graft in the arm. We have several patients that have the graft actually placed in the thigh because they have no veins in the upper extremities. And color grafts, we rarely see them, but those are kind of like last resort in patients that have absolutely no veins in the arms or the legs. So let's just do the advantages of an AV graft. So AV graft, the good thing about AV grafts is the maturation time is short. You can kind of use it almost right away after creation is made, in a couple of weeks. And high success rate when you do have a vein to connect and an artery to connect that are not totally destroyed. So you don't need much. The issues with the AV graft is that they do have decreased flow. They have increased venous pressures, And sometimes they do get clotted a lot. They're easy to open, but at the same time, the chances of getting a graft thrombosis is very high. So just keep that in mind that, we do prefer fistulas because of that, but sometimes you do have to get a graft because you don't have the enough veins to sort of like make the connection. Um, and the majority of them, I will say that the reason why I see them is because they either have failure at the venous anastomosis more than the arterial anastomosis. And the problems with accessing a graft is that they do have a higher chance of infection than a fistula. So, sometimes patients need to have a surgical resection of the fistulas because they're infected. So just be aware that, if you do have a graft and the patient becomes a little bit septic or have some sort of infection, this is the first thing that you need to check to make sure that you don't get into problems with trying to declot or doing anything related to that. So we'll move on. So usually what people are telling me is, what angioplasty tricks do you have, or what angioplasty things do you do? And it's pretty straightforward. Usually, I like to size the vessel first, especially if I don't know the patient, to the size of the vessel. I know that most of those patients will have, or will like to have, about a 6 millimeters in diameter. So I will mainly start with a 6 millimeter balloon if I feel like that's the appropriate size. At this point, you do a lot of them and you kind of gauge about what size the fistula is. But if you're starting to do fistulas, just start from something that is smaller in size to something that is bigger in size. So patients that I have treated with 8 or 10 millimeter balloons, now I know that I can put the 10 millimeter balloon right from the get-go, and I don't have to go in that increment size. But at this point, you kind of gauge what it is. I will say the balloon inflation for me is about a minute. And then after that, I'll see how the fistula sort of like relaxes. But usually about 30 seconds, you will have some sort of smooth relaxation of that vein that has been arterialized. And the majority of them resolve at that time. So size them appropriately. You want to size it just a little bit bigger in the vein than what you need. For the arterial size, you usually want to size it appropriately to the size of the artery that has the inflow. But for the venous side, usually I go like 20 to 40% more of what the vessel is. So, there are complications and stuff that I have, seen, which is the vessel rupture or a hematoma, flow limiting dissection, and I'll show you a couple of those images in a minute. Usually I try to stay as much as I can away from stenting until I can't do it anymore. And then I will size that stent appropriate, and usually about a centimeter, a couple of millimeters above and below where the normal vessel is. So that you kind of make sure that you're covering not only the lesion, but just a little bit above the lesion and below the lesion. And I have seen stents that are undersized that actually fly away and go to the central veins. So you have to size those stents appropriately to avoid migration. The other parts are a little bit more different. I do have seen perforation when they're trying to place a stent if they do something different, but the majority of the time is an undersized or oversized stent the problem. For people that have a clotted fistula, there's several ways to do it. The way that I like to do it is I like to pulse spray TPA. About 4 milligrams of TPA will be enough to sort of declot a fistula in the majority of times of a graft, but you can go to 3 to 6 milligrams of TPA. So you lace it all the way into the thrombus, and then you can either macerate the clot, or you can aspirate the clot, or you can use different devices to sort of like break the clot out. I tend to macerate the clot. That's the way that I was taught. And I have no problems. 95% of the time, those fistulas open pretty easily after you do the TPA and you sort of crush the clot with a balloon. I have other of my friends that are in dialysis access, and what they do is they just aspirate and plasty, and some of them don't even use DPA or heparin. So there are different ways to actually decrease the clot. So there's, to show you here, you will have aspiration of the clot. If you have a fistula that is thrombosed, you can get a large balloon, large catheter to sort of do that. Sometimes what we do is, like in this um, drawing, you can see that we put the catheter in, put the TPA inside, and then macerate the clot. The things to remember about fistula intervention is not what you do for lysis of the clot or aspiration of the clot, is what you do at the level of the arterial anastomosis. So your arterial anastomosis is going to have a fibrin plug. You will never want to take that fibrin plug before you actually have done resolution of the clot within the fistula. That's when you sort of get into trouble. So lyse the fistula or aspirate the clot inside the fistula first, and then you can open up the plug, the fibrin plug that you have in the arterial anastomosis area. This is, again, a lyse technique where you can kind of like put two catheters, one going to the arterial anastomosis, one going to the venous anastomosis, and sort of do the lyse that way and wait for that fistula to open. So a little bit about endovascular fistula creation, because I do it, and I have used both devices. I found the ellipsis device, which is the more you do it more on the ultrasound guided, a little bit better. I think they're great when they work perfect. You just have to make sure that you have the proper anatomy to actually do it. For the WaveLink device, you want to make sure that you have good either radial or ulnar arteries and veins. Sometimes you can create it in the interosseous area. For the ellipsis device, you want to make sure that your collateral system is actually robust, and then you have a communication of the artery and the vein close by. These are the criteria and location of where we're going to create a ellipsis fistula. Usually it's a 2 mm diameter artery, a 2 mm diameter outflow conduit. They need to be not too far apart so that obviously when you get the device in, you don't get into trouble. And I will show you, these are the difference between one and the other. Again, at this point, I think most of us will prefer to do an ellipsis fistula than a WaveLink fistula. But I'm going to show you a little video. This is one of my good friends that have a dialysis access center, and he's doing one fistula in real time. And I will try to sort of go over what he's saying. So these are the wires that we use. These are the balloons that we use, and the equipment that we use. It's a very simple procedure, and it can be done all under ultrasound, as you can see here. So a little bit of local anesthesia, a 21 gauge needle to puncture the venous outflow that you're going to try to create. So that vein, and you can see the puncturing of the vein. This is above where the perforator or where that collateral vein is. And all you have to do is just drive your needle down that collateral vein, as you can see here, kind of like in the middle of the vessel, and keep advancing that needle all the way down to where you get into the collateral system. So this is kind of getting from the cephalic vein to the collateral vein at the level of the elbow or the antecubital fossa. And this is real time. This is not, I'm not accelerating the process or taking away. This is a real time procedure, and this is how long it takes to actually do a endovascular fistula. So once you get close to right here, which is close to your artery, what you're going to do is just puncture the artery. And you will see the puncturing of the artery right here on the ultrasound. He pops into the artery. You're going to see the flow. He's going to do it on the transverse view, and then put the needle on the longitudinal view so that you can see how the artery gets access. And that way you can see your wire sort of going down into the artery. But you see the pulsatile flow right here now. And now I'm going to accelerate this a little bit, so in the interest of time. But there's a wire that goes in, and you can actually see it on the ultrasound. And this is at the level of the radial artery. That's when you know you are in the right location with the wire. And then everything else gets swapped for a sheath before you actually put the device in. And this is how the device will look. So you have the device open, you pull it back into the area where you cross with the needle. The device gets closed and locked, and it takes about a minute to sort of create that fistula. So this is the device getting closed and locked. And you will see a little bit of air sort of in that area once the device gets activated. So we will see that activation in just a minute right here. There we go. And that's about it. It takes about a minute to do that. Everything gets pulled back. This connection is actually so strong that we actually angioplasty the arterial anastomosis as soon as it's created. So this is the angioplasty. You can see the waist right there. And then you can actually see how much flow you got into the fistula after the fistula is created. And this is takes about 5 minutes to create a endovascular fistula. So this is, pretty impressive. Obviously, he has a lot of experience doing that, but you will see that the flow is about 600 after the fistula is created. And all you are left with is essentially a dot of where the fistula was done. And that's about it. This is the endovascular fistula. So these are the dialysis fistulas that I have created that have been all gone to dialysis. The cannulation is a little bit different, but we're going to go to a little bit of cases. This is actually one of my endovascular fistulas when I first started. So we used to actually cannulate the artery and the vein. Had the device placed. This is the original device, and you can actually see right here how the device sort of like gets engaged into the foot plate, and that's how the fistula gets created. And this is essentially our fistula creation after the wavelength device. You can see the communication. This is an artery injection, and you can see the vein going out. Essentially, the communication that we did was about the ulnar artery. And these are the two entry sites for that. So excellent way to actually create a fistula when the candidates are appropriate. So I'll show you a few cases just in the interest of time of what we do. So remember what I said, you have to evaluate your fistula from the arterial anastomosis all the way to the central veins. So this is the way to evaluate your arterial anastomosis. On this patient, we did have poor cannulation and poor and recirculation on the fistula. So you can see the stenosis right there. This is the central veins. Then we use the balloon to angioplasty the areas of stenosis, and this is resolution of that area of stenosis there. So these are the simple cases that you will like to get most of the time. Obviously, I don't tend to get this. I get the more complicated things. So this is a loop graft, and you can stop me at any time and just ask for questions. If you do have questions, please feel free to ask. So the loop graft looks like this. When it's thrombosed, obviously we don't want to inject, we don't want the clot to sort of like get out, but we start evaluating the fistula from the central veins all the way back until we find the clot location in the central veins. And then we sort of do a lice and weight technique. This is us angioplasty after we did the TPA, and now the fistula is open. And you always want to know what the issue was with the fistula and where the problem is so that you can angioplasty. And in this location, it was the venous anastomosis that was the issue. So things go wrong sometimes when you angioplasty, especially around the cephalic arch or where there's a tight stenosis. And then these are the issues that you get into it. You get contrast extravasation once you inject. You can easily fix those contrast extravasations with a stent. What I tend to tell the residents is never, never, ever take the balloon out of the wire before you actually inject the fistula. So in case you need to put back your balloon again, you're not freaking out that you need to get it back into the wire. So take it out, get it out of the sheath, inject your fistula. If you see something, you can push your balloon back again and inflate it until you figure out what you're going to do next. And so that's a very useful tip that, saves a lot of anguish once you're doing something that goes sideways or south. So this is an 83-year-old male with left upper extremity arm swelling and pain, high venous pressures on dialysis. And as you can see, this patient does have a severe stenosis of the central veins. There's nothing going centrally. There's all this collateral circulations right here. And, we just need to find a way to cross that. And at this point, you can see contrast in the IJ coming down into the central vein. So this area was completely occluded. We angioplasty. Sometimes you're going to get some contrast extravasation where you're trying to recanalize patients' really severe occlusions, right? So that is totally fine. The whole point of this is that at the end, that patient is going to get a stent. So you can see the whole mess when we did the final injection prior to putting the stent. And all of that went away once you stented this area. But this usually is not a case that happens really quickly. It takes a couple of hours for you to sort of recanalize that vein and sort of putting your stent in. This is how it looks after completion of a couple of stents, and the patient did fantastic. Hold on one second. Hey guys, keep it down, please. Sorry, they having a meeting outside. This is a 62-year-old male with a thrombosed right upper extremity fistulas, AV fistula. And, I said that fistulas are usually less prone to thrombose than graft, and that is true, but sometimes you need to find the reason why these fistulas went down. So this is the arterial anastomosis. You can actually see that there's clot in the arterial anastomosis, but more than clot, there's no flow going down the fistulas. We did angioplasty, we did TPA, the usual stuff on that. And you can actually see that after we did all that, we still have no flow. So this patient actually around this area had a dissection that was caused either from previous intervention or us trying to sort of like advance stuff through it. So the only way to fix this is to stent that area. I hate stenting close to the arterial anastomosis if I can avoid it, but this is something that will only be fixed with that. So this is a expandable stent that we actually place in this location. And this is how the fistula looked after we actually resolved the problem. And the patient went on to have dialysis without any issues. These are puncture-resistant stents, so they can actually puncture in that location. And over time, the stents might get a little bit damaged, but they're able to actually do that because it's as a puncture-resistant stent. It's a 52-year-old male with prolonged bleeding after dialysis. So you know that those patients tend to have a problem in the venous outflow. So once those patients develop some high resistance in the venous outflow distally, they start to develop some aneurysm dilatation of your fistula, which is where we actually got in there. You can see the severe stenosis in the central venous outflow. And the central outflow looks pretty good, but we did angioplasty in this location where the patient had also a previous stent that was really mangled. And then the fistula was corrected. So this is a 40-year-old female with left lower extremity AV graft and a clotted graft. And this was very interesting because when they placed the graft, they actually didn't know that the patient had a May-Turner syndrome. So it's a combination of a graft and May-Turner's. So you have to fix the outflow problem, which is the May-Turner. So we stented that and then took care of the graft. So remember that May-Turner can occur in patients that you can actually fix the problem of patient that has a graft in that location or a thigh graft. So 83-year-old female with a clotted fistula. And these are the fistulas that sometimes you get into it. Those are the aneurysmal dilatation of the fistulas. And what we hate the most is sort of having this big aneurysmal dilatation of a fistula full of clot, and how do you sort of take care of that? So the usual part, this is the Fogarty balloon that is inflated at the level of the arterial anastomosis when you are almost done with your fistula. And we thought that we were done with the fistula at that point, but the aneurysmal dilatation of that fistula was still full of clot. So we used the Argon device. It's called the cleaner. And this sort of turns on itself. You can actually compress it with the ultrasound and sort of like get rid of the clot all the way down. Eventually, we got that fistula open, but this usually takes several minutes. And then we found out that the patient does have a stent right here and it was totally occluded. And we just needed to sort of find out our way into the central veins. So this actually, I did it from the groin and went into the cephalic, into the innominate vein, and was able to cross the stent in the opposite direction. And then find my way to sort of catch that wire inside that snare there, snare it out, and then was able to do my balloon angioplasty. So I had through and through wires, which made it made it easier to put a stent. So those are the cases that I have. I hope that this is a little bit more entertaining, and let me know if you do have questions. I'll happy to talk to you about any of the stuff that I talked. Let me see if I can see everyone here. Any questions, guys?
So far, I think it's well understood. Or if there's any fellow with question.
Are you doing any fistulas there yet? Are you doing any fistulous intervention, angioplasty?
Yeah, we do a lot.
Okay, that's great. Is there anything that you guys get stuck on that you want me to sort of help you out with?
We encounter a lot of issues with clotted fistulas.
Okay. And what are you using to open those fistulas?
So we were asking like, what's the cutoff time? Like most of the time we receive patients that come maybe a week later, they found out that the fistula is not working. So others come maybe 4 weeks later. So we
Okay.
are kind of having a lot of challenges on how do we, what time, like what's the cut-off point of declotting a fistula?
Yeah, so in a fistula, you want to get it as soon as possible. We tend not to see it on fistulas very much here. When the patient is clotted, we within 24 hours, we try to open it. A graft is a little bit more, you can let it go for a couple of more days. So, if it's over the weekend, we might just wait for Monday to actually do it. Although if there's someone that likes doing this stuff, we will do it over the weekend. We tend to forego grafts that are occluded a little bit longer than fistulas. But fistulas, we tend to do 24-hour. So if the patient comes in either the same day, we'll try to declutter, or the next day. But for the most part, we don't want to leave it for weeks, because then they get shut down and it's extremely hard to open them again. Grafts are a little bit more, you know, you can work around it, because you can puncture it and figure it out and try to see if you can open it again. But still, the sooner you get to it, the better it is. So I guess the point of this is trying to figure out a system that when those patients sort of get clotted, and I know the implications of that is people traveling from far away. They try to get to a point that you can get them sooner in. But there are ways to work around that, especially when there's a graft. So I guess you guys are working hard to open those fistulas up.
Um, so for instance, if you don't have a foregut balloon, what do you usually use? What can you use?
If you don't have a Fogarty balloon, I will say you can use a small or a short 2 millimeters balloon that is not more than 5 millimeters, to kind of pull it around, with the notice of you're going to have to probably deflate the balloon a couple of times before you pull it out. The Fogarty balloon is a little bit more compliant. The angioplasty balloons are not that compliant. You can also aspirate that, try to aspirate into the fistula that fibrin sheath. For the most part, I tend to use a balloon just to pull it out back. But in places that you don't have a Fogarty balloon, try to use a 2 millimeter balloon if you can get one of them.
Thank you so much.
You're welcome. You guys have a good day. I'm sorry for the delay, but I can't control the weather.
It's fine. Thank you so much.
All right, take care.
You too.